Hello and welcome to the Radiology Scholars Certificate Program. My name is Nick Cantillo. I'm an MS4 at the Wake Forest School of Medicine, and in this video we'll be covering CNS infections, a localization-based approach. This will be part 1, covering extraaxial infections. To begin, it's important to define what we mean by extraaxial when we're talking about extraaxial infections. So the extraaxial compartment includes the epidural space, the subdural space, the meninges, and the ventricles. That can be partially shown here on the diagram on the right. This is in contrast to the intraaxial compartment, which more so contains the neural elements, including the cerebrum, the cerebellum, and the spinal cord. So to begin, we'll cover infections involving the epidural space. This is the space between the inner surface of the skull and the outer surface of the dura mater. These are referred to as epidural abscesses, and these are caused either as post-traumatic. They can be post-surgical after a cranial neurosurgical procedure, can be due to extension of an infection involving the sinuses, inner ear, nose, things like that. It can be also as a complication of IV drug use due to the hematogenous spread of bacteria. Organisms that are typically implicated in these infections are Staph aureus, especially common in post-traumatic and post-surgical epidural abscesses. It can also be caused by anaerobes, which would be more common in epidural abscesses caused by extension of an ENT infection. The pathophysiology involves either the contiguous or hematogenous bacterial seeding of the epidural space. This leads to the formation of an abscess, which is essentially just a walled-off collection of infectious and inflammatory debris. And this can cause compression of surrounding neural structures, which can lead to neurological symptoms, and if very advanced, can lead to herniation syndromes, which can be fatal. Imaging findings of epidural abscess typically see a peripherally enhancing lesion that centrally restricts diffusion, meaning that it will be bright on DWI, or diffusion weighted imaging, and dark on ADC, which stands for the apparent diffusion coefficient. So bright on DWI, dark on ADC, with peripheral enhancement. So here we see a few representative images of an epidural abscess, this one being cranial. As we covered on the last slide, epidural abscesses classically restrict diffusion centrally and peripherally enhance, and that's what we can see very well here. Once again, that means that they're bright centrally on DWI, dark on ADC, and show brightness or peripheral enhancement along the outer rim of the abscess, which you can see very well in the T1 contrasted sequence on the right. Another interesting finding here, you can see a bit of involvement of the subperiosteal space overlying the frontal sinus. This is referred to as a Pott's puppy tumor, Pott's being the same guy that named tuberculosis of the spine as Pott's disease. Obviously, this is not actually a tumor. It's a bit of a misnomer. It's referring to a subperiosteal abscess over the frontal calvarium. Here we see an example of a spinal epidural abscess. Here the arrows are pointing out these peripherally enhancing epidural collections over the dorsum of the spinal cord. These would be consistent with a spinal epidural abscess. So now that we've covered the epidural space, we can move on to the subdural space. This is the space located between the inner surface of the dura and the arachnoid. These are referred to as subdural empyemas, which is a bit of a different terminology from what we referred to for the epidural space, that being an abscess. Very similar processes, just slightly different terminology. Etiology is very similar to that of epidural abscess. It can arise post-traumatic, post-surgical, can be due to an infection of a subdural effusion, and similarly to epidural abscess, can be due to extension of an infection of the inner ear sinuses. Organisms typically implicated in subdural empyema are Staph aureus, again, especially common in post-traumatic, post-surgical causes, and anaerobes. Pathophysiology is similar to epidural abscess again. It can be due to continuous or hematogenous bacterial seeding of the subdural space, leading to the formation of an inflammatory infectious collection termed an empyema. This can cause compression of neural structures, leading to neurologic symptoms. Classic imaging findings are similar to those of an abscess, once again seeing the peripheral enhancement with central diffusion restriction. Again, that means that they're bright on DWI and dark on ADC. So here we have a few images, examples of subdural empyema. As is classic for an abscess, for an empyema, we see the classic findings of peripheral enhancement, sort of along the margins of the collection, which is here indicated by the arrows along the left cerebral convexity. And we also see evidence of diffusion restriction, as evidenced by the brightness on DWI. The ADC sequence is not shown here, but this would most likely appear dark on the ADC sequence. So we've covered infections of the subdural and epidural spaces. Now we'll cover infections of the meninges themselves. This is referred to as meningitis. The etiology of meningitis can be post-traumatic, post-surgical, can be due to mucosal invasion of bacteria that are located in the nasopharynx, and can be due to contiguous spread. Organisms classically implicated in meningitis can vary a bit in prevalence by age group. However, most common overall are strep pneumo, group B strep, Neisseria meningitidis, H. flu, and listeria. The pathophysiology of meningitis involves the contiguous or hematogenious bacterial seeding of the meninges and the subarachnoid space. This causes inflammation of the meninges and inflammation of the arachnoid granulations, which serve an important role in the resorption of CSF. And when there's impaired resorption of CSF, this leads to excess CSF accumulation, which can cause elevation of ICP, leading to neurologic symptoms. Classic imaging findings for meningitis, they're often normal. However, there can be meningeal enhancement. This causes hyperintense appearance of the meninges, particularly best seen on the T2 flare sequence. So here is an imaging example of the findings seen in meningitis. As we mentioned on the previous slide, imaging findings are often normal. Therefore, imaging is most useful to screen for complications of meningitis, such as infection of surrounding structures, extension of infection to other intracranial compartments, or venous sinus thrombosis, which are all complications of meningitis that can be potentially identified using MRI. This is a coronal T2 flare sequence, meaning that CSF should appear dark. The signal should be suppressed. That is evident here in the sylvian fissures. However, in other sulci, that is not quite as evident, meaning that there is some complex proteinaceous material located in the CSF that is preventing the suppression of the signal on the flare sequence. And that is something that can be seen with meningitis. So the final entity that we'll cover in this video is infection of the ventricles, which is termed ventriculitis. The etiology of ventriculitis can be post-traumatic, can also be post-procedural, particularly procedures that involve access of the ventricles, such as an EVD or an external ventricular drain, or a shunt, in which a catheter is passed into the ventricles in order to drain off CSF and treat hydrocephalus. This can also be seen in other neurosurgical procedures in which the ventricles are entered. And finally, can arise due to extension of another intracranial infection, such as meningitis or cerebral abscess. Organisms that are commonly seen are gram-positive cocci, or GPCs, also gram-negative rods, or GNRs. The pathophysiology involves the bacterial seeding of the ependymal lining of the ventricles, either by contiguous spread or hematogenous spread. This causes inflammation within the ventricle space, which can lead to a variety of complications. For one, this can impair the permeability of the blood-brain barrier, which can worsen hydrocephalus. And if there's a catheter present, such as in a patient with a shunt or an EVD, the inflammation can essentially clog off the catheter, causing it to malfunction and leading to accumulation of CSF within the ventricles, which can cause various neurological symptoms. Imaging findings for ventriculitis will classically see ventricular enlargement that is due to the the pathophysiology that I just covered, the impairment of the permeability of the blood-brain barrier, and if applicable, malfunction of the catheter causes accumulation of CSF in the ventricles, causing them to enlarge, which will be visible on imaging. You can also see layering of inflammatory debris that restricts diffusion within the ventricles. As a reminder, diffusion restriction will appear bright on DWI and dark on ADC. And you can also see enhancement of the ependymal lining of the ventricles, which, as mentioned above in the pathophysiology, is due to the inflammation of the ependymal lining. So here's some imaging examples of ventriculitis, which is a very serious infection with a high mortality rate. On imaging, we're seeing signs of hydrocephalus. We see ventriculomegaly, or expansion in the size of the ventricles. We see evidence of material layering within the ventricles that restricts diffusion. That's evidenced by the brightness on DWI and the darkness of that material on ADC. In these examples, we see that in the occipital horns of the lateral ventricles bilaterally. And we also see ependymal enhancement. That's best seen here on the T1 contrasted sequence. We see that brightness of the ependymal lining of the ventricles. So that these images are very good examples of all the findings that you can classically see in ventriculitis. And that wraps up this video, part 1 of CNS infections.